Good morning, everybody. I'd like to thank organizers of live conference, in particular, Ma'am Kamini Rao, for being kind enough to include me as part of this conference and giving me the liberty to put two of my talks together in a cohesive way, and I'll try my best to do that. After seeing how ovary as an organ has been endowed with some very special qualities as far as the circulation and vascularity is concerned, we will see what are the dynamics that are happening within the follicle. As you rightly said, to us infertility specialists or fertility specialists, ovary is all about follicles. So we know that ovarian follicle has two very important functions. One we are all very passionate about, that is reproductive function or gametogenesis, and the second, which we not often think about, that is steroid biosynthesis. And follicle actually has this dual role to play. And when we think about ovarian reserve, it's very important to know that the highest number of follicles are present in the mid-fetal life, about 6 to 7 million, which reaches to about 1 to 2 million at birth. And by puberty, it is down to 3 to 5 lakhs. And by around 37 years of age, it is down to 25,000 when the accelerated decline starts. And by 51 years, it is down to 1,000 when menopause occurs. So it translates to that less than 0.01% of the entire follicular pool eventually result in ovulation. And this is mainly because of destruction of the large volume of primordial pool from 5th month of gestation to birth, because ovary somehow recognizes that many of them contain abnormal oocytes. This is the hypothesis. And post-delivery to puberty, it is all atresia of the follicles, and following that, from puberty to menopause, atresia still continues to dominate, but then there is that small element of ovulation also, which leads to complete exhaustion of the ovarian follicular pool. So when we talk about follicular dynamics, we talk about two things. One is the growth of the follicles as a cohort and what's happening within each of these follicles. And there are two very important things to understand here, that the true ovarian reserve, what we want to know, that is the pre-established ovarian reserve, which means the primordial follicle, we have no clue how to estimate this. What we are looking through various forms of ovarian reserve markers is what we can call as dynamic reserve from the signals given by FSH responsive follicles. In humans, it means about follicles of 3 to 5 millimeters and more than that. And AMH comes in between these two. AMH is a unique molecule which sort of links the primordial follicular pool to the ones which become FSH responsive in future. So we'll refer to that a little later. So when we look at follicular recruitment, I think all of us are very familiar with this particular diagram, but what we need to understand is that the primordial follicular pool sitting there can take years before it reaches the growth phase. And once it enters the stage of recruitment, it goes through stages of primary and secondary follicles, which can take up to 200 days. So from here onwards, the follicle is destined to either undergo apoptosis or ovulate once it gets into the recruitment pool. And once it reaches the size of antral follicle or 2 to 5 millimeters in diameter, then they get selected to grow and eventually become atretic, or one of them in each cycle leads to ovulation. But we do know that the size of the follicular pool, primordial follicle, is not very similar in different individuals. Whatever is the size, there is a rate limiting step between the primordial pool and the growing pool, and where various factors including AMH play a very important role in deciding what is the rate of recruitment. So one of the molecules which is very extensively studied in the recent years, particularly in animals, is BMP, which is a bone morphogenic factor, and AMH, of course, as we are very familiar with that, to see how it controls the recruitment. But in human, again, it's not very clearly understood. Now, depending on, if we look at the lower part of the diagram, depending on the size of the primordial pool, the rate of recruitment differs. Those who have a high reserve, they recruit more follicles continuously, but eventually result in ovulation of one follicle every cycle, which means there is a high rate of atresia. Whereas in those who have a low size of the primordial follicle pool, the recruitment also happens at a slower rate, eventually also resulting in one ovulation and less atresia. What is important is that many times we get to hear that, you know, the AMH is very low, but this patient ovulates regularly. What we need to remember is that ovulation has got nothing to do with the ovarian follicular pool size until it reaches below 1000. You know, a woman will go on ovulating until almost the ovaries are exhausted of the follicles. So that's not a marker of ovarian reserve. It is the size of the pool which is more important. So the rate limiting step between the primordial follicular pool and once it enters the recruitment phase, it's the most interesting phase, and that is where a lot of studies are taking place to see whether we can, what mutations happen at this stage to affect the ovarian reserve and whether we can manipulate it to our advantage. So once, you know, in the normal course of events, when the recruitment takes place, there is the recruitment, you know, we think that it is cyclical, that it starts at the late luteal phase and then continues to result in ovulation of one, atresia of the others, but it's not so. It's a continuous process that nearly about 30 to 40 follicles in a woman with normal ovarian reserve at 25 years of age, 30 to 40 follicles are getting recruited every day. So it's not a cyclical thing. And when the recruitment happens, the size of the follicle starts increasing. There is no increase in the size of the oocyte as yet in the beginning. But when the woman reaches the stage of either age of 37 or the size of the follicle pool, primordial pool reduces to 25,000. That seems to, 25,000 seems to be the critical value when there is, there is an accelerated decline in the ovarian reserve. There is sudden increase in the recruitment that happens. So even though the number is reducing, there is also increasing recruitment. So the woman starts exhausting her ovarian reserve very quickly. So it's very important to remember that 25,000 or 37 years marks a very important phase of rapid decline in fertility for women. So what are the deviations that could happen? Either somebody could be endowed with a high primordial follicle pool and hence a high recruitment rate, or very low or absent or early exhaustion of the entire primordial pool. And as I mentioned, in animal studies, they are trying to modulate various pathways involved in controlling this step, either through gene manipulation or through various paracrine pathways, including modulation of AMH production, to prevent both early exhaustion of the pool, and they have been successful in doing that in some mice studies, and also to exhaust the pool to certain extent in those who exhibit the features of PCOS, so that, you know, it comes down to the usual rate and then normal ovulation begins. So it's not only about ovulation, you know, this has importance for the general health of women who are affected with PCOS as well. I mean, these studies have not been conducted in humans, but these studies are going on very intensively in various animal models. So once they are recruited, they go through the primary and secondary follicle stage, where gradually there is increase in the size of the oocyte and huge amount of production of mRNA, which is necessary for protein synthesis around the time of ovulation. The oocytes which did not have zona pellucida now develop zona pellucida, and the granulosa layer increases in size, and then they become very sensitive to, responsive to both FSH and LH. From this is the stage from which we understand what happens to an ovarian follicle. They become responsive to FSH when they reach around 2 to 5 millimeters in size. We can start seeing these follicles on the ultrasound, and we are very aware of what happens here onwards. So either they undergo atresia. I'll just take a minute to talk about atresia, because it's the normal fate of most of the follicles, and all the hormones we talk about have an impact on this, and it dominates the fate of the follicle throughout childhood. And at puberty, some of them get rescued because of the sensitivity they develop to pituitary gonadotropins. And various mechanisms have been put forward to say why atresia happens in ovaries, because gametes are to be, female gamete has the responsibility of procreating and creating the next generation. So it has to be, it carries a very important information to do that. So quality control is one of the mechanisms which is considered to be the reason for such a high level of atresia happening, or deficit of survival factors, or a mechanism of self-sacrifice, because this atresia happens through what we call as death factors, which act both at the extracellular level and have disrupt the function of various cytoplasmic activities, or they happen within the mitochondria, again disrupting the both cytoplasmic and nuclear function. So if the survival factors are not there to balance this, again these women can have a high level of atresia. So for a follicle, it appears that being in the right state and place at the right time is most important, which means that it should enter the growth phase in the late luteal phase, so that it becomes sensitive to FSH at the right time, and then eventually can hope to ovulate. If it is not starting to grow at that time, if it starts growing at any other part of the cycle, it is going to end up in atresia. So those who enter the growth phase at the right time, so they go through this period of selection where they become very sensitive to FSH and subsequently LH. They start producing the steroid, that is estrogen. There is great increase in the size of the follicle, so we can observe these activities on ultrasound because of fluid accumulation, and increasing levels of E2 and inhibin, which provide a feedback mechanism to stop the secretion of FSH. So this limits the growth of many follicles and allows one follicle to grow further, which becomes more sensitive to the static level of FSH. And finally culminates in ovulation, induced by the LH surge, which leads to resumption of meiosis and cumulus expansion, amongst a cascade of things that happen at this stage. So what we understand easily is the last 14 days of follicular dynamics, influenced by the classical pituitary hormones, including FSH and LH, sex steroids and inhibin A and B, and what happens prior to that is something, which still remains a major enigma. So just to highlight a little bit more on follicular recruitment happening, not in a cyclical fashion, but throughout the cycle. This is a study which has looked at what is happening as visible on ultrasound from one ovulation to another ovulation. Here we can see that there are can I go back? Yeah, it's not happening. It's just not happening. Anyway, I think you all saw the two waves happening. Most of the cycles experience 2 to 3 waves of follicular growth happening, but only when it starts happening at the time of late luteal phase, some of them become sensitive to FSH, responsive to FSH, and then eventually lead to ovulation. But the rest of the waves, which are happening at different times, most of them may grow up to even 14 millimeters in size, but eventually end up in atresia. So how do we evaluate these follicular dynamics, normal and abnormal? One of the other things important to remember about this waves of growth of follicles is we can actually manipulate these waves to allow more than one set of follicles to grow in each cycle, which becomes very important in women with very poor ovarian reserve, or those who are going through fertility preservation techniques before being treated for various malignancies. So these are the two instances where it's very important to remember that we can actually stimulate them more than once in the same cycle. So how best can we evaluate what's happening to these follicles? So it's just not moving. Can you go to the next slide after that, please? Basically, we know that most of the markers of ovarian reserve which we use, whether it is FSH, whether it is antral follicle count, whether it is inhibin B, All these are reflecting what is happening to the stages after recruitment, once the follicles become responsive to FSH. But that part where the follicles are entering from primordial pool to the recruited pool, where they're still not sensitive to FSH, it is almost unexplored, and the only molecule we know of at present which can actually give some insight to this particular step is AMH. So this, that's the one. So this diagram very eloquently shows that the relationship between various markers and the stages of folliculogenesis. So AMH is the only molecule which is actually, it's the most direct reflection of the primordial follicle pool we have at present. Can you go to the next slide, please? So if you look at what's happening to the follicular recruitment throughout reproductive life and the AMH secretion throughout reproductive life, the curves are very, very similar. So we can say that AMH actually reflects the recruited follicles throughout the reproductive phase. But if we look at where it peaks, it is around 25 years of age. So if somebody between 20 to 25 years of age has slightly lower AMH, we should not jump to the conclusion that that girl has got low ovarian reserve, because we know that there is some peak happening at 25 years and only then the decline starts. So be very wary of labeling somebody as having poor ovarian reserve when all the other markers are normal and only AMH is slightly on the lower side if she is below 25 years of age. Now this is the non-growing follicular pool from animal studies related to different age groups. So if we look at somebody at 30 years of age, we see the distribution between the 95th median, 95th and 5th centile, and both 5th and 95th centile are considered to be normal. But if we look at the magnitude of difference, there is 100-fold difference in the size of the follicular pool. So these two women on the 5th and 95th centile will not have the same kind of ovarian reserve, so their reproductive potential is not the same. And this is very clearly shown through AMH. When these women are stimulated through controlled ovarian hyperstimulation, they grow very different, they respond very differently, they grow very different number of follicles, and this is very clearly reflected in AMH, and at any given point of time even AFC can show this difference. When we talk about ovarian aging, we know that, so from the graph I showed earlier, not everybody has the same size of the follicular pool, primordial pool. So 1 in 10 women attain menopause before the age of 45 and 1 in 100 before the age of 40, and fertility starts declining rapidly 13 years prior to menopause. So 1 in 10 women of 30 years and above will have reduced fertility, and this is something very important to remember. And a study done in IVF patients has shown that in Indian women, this actually happens 6 years in advance. So if we are talking about 35 years in a Western woman, maybe it is equivalent to 29 to 30 years in Indian women. So we need to extrapolate all the information I'm giving to you, to Indian women, and be very wary of what is happening to our ovarian reserve. So prediction of ovarian reserve has 3 important roles to play at any given point of time for infertile women going through either any form of treatment or controlled ovarian hyperstimulation for IVF, what her response is going to be like. And over a period of time, if somebody wants to know what her fertility potential is, if she's going to delay pregnancy, and can it at all predict pregnancy outcome. And AMH again scores above all other markers. You will have more detailed discussion throughout the day. But as we stand today, AMH has a very important role not only in predicting what is the response to any kind of ovarian stimulation and how we can individualize the treatment, for which we make use of it most often, but now we do have some evidence that it can predict live birth rate and can help in counseling women on their reproductive lifespan. So we know that both AMH and AFC are very equivalent in predicting both hyper response to controlled ovarian stimulation or to poor response. There is absolutely no argument about that. They both have similar sensitivity and specificity, and because of that, now there are very good criteria provided how we can individualize the controlled ovarian hyperstimulation protocols for women with different kinds of ovarian reserve, normal, hyper or hypo, so that we can actually aim for the safest and most effective stimulation strategy. But can any of the markers predict whether somebody is going to achieve pregnancy or not? We know that age is the most important factor, and we know that all etiological factors influence the success rate. But independent of all those things, we know that the number of oocytes a woman yields has a direct bearing on whether she will conceive or not. And there's a significant difference between somebody who yields 3 or less number of oocytes and somebody who gives 15 oocytes as to her chances of achieving pregnancy. And this has been showed in very large data sets. And we know that AMH reflects the oocyte yield it's a very sensitive marker for the oocyte yield. So we can extrapolate and say that AMH indirectly can predict live birth rate. But now there are 2 studies which have directly looked at AMH values across all age groups and shown that an older woman who has normal or good AMH value has a better chance of achieving pregnancy than somebody who is very young and has low AMH. So AMH above 25 years of age, low AMH, has to be treated with some and great respect. In addition, there have been studies with various markers to see whether they show any changes over a period of time. So linearly, whether we can define somebody's reproductive potential. And AMH is the only marker which has shown as early as 25 to 30 years a decline over a period of time compared to all other markers including AFC, FSH, and inhibin B. And this is a study from a normal population, not an infertile population, where they have seen whether we can correlate various markers to the age of onset of menopause. And again, AMH is the only marker which can tell us the relation from one time point to menopause based on its value. And if you look at the second column, the second box there, we can say that if AMH is below 1, she has about 10 years to go through menopause, which means that the accelerated decline has already started for that woman and her fertility potential is already declining. And there's been comparison of general population and infertile population. The AMH and AFC values are very similar. So there doesn't seem to be any difference in infertile women's ovarian reserve and general population's ovarian reserve. It's very important to know that because, when we talk about oocyte donors or when we talk about our own daughters and daughters-in-law who want to continue in their career and delay childbirth, this is very important information that if the reserve is low, irrespective of whether she's proven infertile or not proven, there is a chance that the chances of pregnancy is declining. There's been one major confusion with AMH because of the different kinds of assays used, but now we finally have automated assays which can actually predict the ovarian reserve, and it has eliminated the problems of lab issues of very laborious process, the impact of keeping it at room temperature, impact of keeping it at freezing, all these have been eliminated. And this is a very stable assay available now, and I think universally people have switched over to these two completely automated assays. So in conclusion, understanding follicular dynamics may have futuristic role in improving fertility and longevity of reproductive span by controlling the rate of recruitment and also rate of apoptosis. Currently, increasing understanding has led to the evaluation of role of various markers, and AMH has proved not only as a good marker of ovarian reserve, but is considered to be the best available marker to predict ovarian aging. And various controlled ovarian hyperstimulation strategies can be utilized, understanding the follicular dynamics to harvest more than one cohort of eggs within a cycle, which is very valid for fertility preservation in malignancy-affected young women and in those with poor ovarian reserve. Thank you.